Hey, welcome everyone to our Institute for Brain Health and Dementia, our seminar series. We are very pleased to have our fifth seminar of this series, and today we welcome Dr. Deborah Levine. She is a professor of medicine in the departments of internal medicine and neurology at the University of Michigan Medical School. She is also a practicing physician. Dr. Levine is the director of the Cognitive Health Services Research Program at Michigan, and her research aims to improve the prevention of dementia and stroke, increase health equity, and impact public policy. Her primary interests are vascular cognitive impairment and the quality of cardiovascular disease care. Dr. Levine cares for stroke survivors in the University of Michigan General Medicine post-stroke clinic. She is a recognized expert in vascular cognitive impairment and secondary stroke prevention. It's our pleasure to have you here today, Dr. Levine, and please take it away.
Thank you. Thank you, Loretta. Thank you for the kind introduction. I appreciate the opportunity to speak with you today. I'm a huge fan of Dr. Power and her work. She's a talented scientist doing policy-changing research, and it's a pleasure to join the GW Institute for Brain Health and Dementia in this series. So before we dive into the research, I want to express my heartfelt gratitude to the George Washington University Hospital team. I recently fell and suffered a severe ankle fracture on a business trip to Washington, D.C., and the GW University Hospital team gave me top-notch care and put me back together. So I'm very grateful. Here are my disclosures. The pooled studies I'll present today were supported by the NIH, as were the 7 cohort studies that provided data. So what's the goal of my work? So the goal of my work and that of my team is to help adults have good brain health, namely by reducing their risk of stroke and dementia. This goal motivates my clinical work. I founded the University of Michigan General Medicine Post-Stroke Clinic to help stroke survivors reduce their risk of recurrent strokes, which are more lethal, disabling, costly, and dementia-inducing than first strokes. The goal of helping adults maintain their brain health motivates the University of Michigan Cognitive Health Services Research Program, which I direct. And the goal of helping adults have good brain health motivated the 2 studies I will discuss today. The talk has 2 objectives. The first is to share results of 2 pooled cohort and simulation modeling studies. And the second is to share perspectives on the process of harmonizing cognitive data across cohort studies, since this is a novel research methodology that we've used in both studies. I've left plenty of time at the end for discussion and questions. So in both studies, we are using a pooled cohort and simulation modeling approach to guide research on dementia and inform clinical care. The pooled cohort and simulation modeling approach has significant novelty and value. This approach already has been innovative by showing that lower vascular risk factor levels are not always better for all patients and might be harmful, modifying clinical guidelines and policies and advancing the field. We have refined and improved this pooled cohort and simulation modeling approach by extending it to a new clinical outcome, dementia, and extending it to new clinic populations, stroke survivors, to create a new simulation model that can similarly modify clinical guidelines and policies. There are 2 studies, BP-COG and stroke-COG. BP-COG focuses on blood pressure and cognitive decline. Stroke-COG focuses on post-stroke vascular risk factors and cognitive decline. We will start with BP-COG. So the problem is that there are racial differences in dementia in the United States. Older Black adults are up to twice as likely as older adults to have dementia. And based on Dr. Power's work, this disparity did not narrow between 2000 and 2016. We know that high blood pressure, particularly in midlife, is associated with a higher risk for dementia, and that Black adults have worse control of high blood pressure than white adults in the United States. Evidence is emerging that the effect of high blood pressure on cognition and racial differences in blood pressure control might begin in young adulthood. So one knowledge gap we addressed in BP-COG is the extent to which worse blood pressure control and higher blood pressure levels over the life course explain the greater risk of cognitive decline in Black adults. Another problem is how blood pressure treatment prevents dementia and the evidence for or against that. So does treating blood pressure prevent dementia? We know from clinical trials that lowering blood pressure to optimal levels, less than 120/80, reduces cardiovascular disease events and the combined outcome of mild cognitive impairment and dementia in adults with high cardiovascular disease risk. But this group in the United States is relatively small. There are more knowledge gaps that we sought to address in this study. It is unclear whether lowering blood pressure to optimal levels reduces cardiovascular disease and dementia in the larger group of adults at lower cardiovascular disease risk. Whether blood pressure lowering reduces dementia disparities is unknown. So the BP-COG study uses a pooled cohort and simulation modeling approach to address these knowledge gaps. And the BP-COG study had 3 objectives. The first was to determine the association between blood pressure levels and later life cognitive decline in Black and white adults using pooled cohort analysis. The second objective was to estimate the potential impact of blood pressure treatment strategies optimally implemented on the population level on racial disparities in dementia using simulation modeling. And the third objective is to determine the parameters of trials that are adequately powered to find a clinically important effect size of blood pressure lowering on dementia and cognition, also using simulation modeling. So the first step in the BP-COG study was to examine the association between blood pressure and later life cognition in Black and white adults using the pooled cohorts. And this was important because we need these results to input into the simulation models. We published these results in JAMA Neurology a few years ago, and I'll present the results of this paper in detail so you understand the general approach that is used in the BP-COG and stroke-COG studies. So our research question was, does Black adults' worse blood pressure control and therefore higher blood pressure levels starting in young adulthood contribute to their greater risk of cognitive decline than white adults? We hypothesized that differences in cognitive decline between Black and white adults are partially explained by Black adults' worse blood pressure control and higher blood pressure levels over the life course. To address the research question, we performed a pooled cohort analysis using individual participant data from 5 longitudinal cohorts between 1971 and 2017. So why were these cohorts chosen? Obviously, they needed to have repeated blood pressure and cognitive measures over time, but they also were chosen to cover the adult lifespan from age 18 to 95 at first blood pressure measurement and provide geographic age and racial disparity. So we included the Framingham Offspring Study, CARDIA, the Northern Manhattan Stroke Study, MESA, ARIC, and CHS for the Cardiovascular Health Study. The MESA data were not ready yet for this first paper, but has been used in other papers. So we were trying to use a life course perspective. Although Framingham Offspring Study has predominantly white adults living in one US geographic region, you can see it's the only cohort with adults 18 to 95 at baseline. This graph shows the participant age at baseline, and the cohorts are shown in individual rectangles. So CARDIA recruited people who were age 18 to 30 at baseline. 3 of the cohorts recruited folks in midlife, and the Cardiovascular Health Study recruited folks who were 65 and older. And as I said, Framingham Offspring Study included people who were age 18 and 95 at baseline. And here's a plot of the cohorts with each cohort given a row. And we can see the visits that occur longitudinally in the cohorts. And the salmon color boxes show where the visits where blood pressure was measured. And the blue colored boxes show visits where cognition was assessed. And obviously you can see that there's heterogeneity in the timing of the visits and the time between visits across the cohorts. So we co-calibrated 126 cognitive test items from 32 cognitive instruments into domains for global cognition, memory, and executive function using item response theory methods. And the primary outcome was change in global cognition. And at the end, I'll talk about how we harmonize the cognitive data, because I think that's an important topic, particularly for the students who are in the audience. So the sample included more than 19,000 participants free of stroke and dementia. 20% were Black, 55% were women. And the median follow-up was 12 years, and the 25th to 75th percentile interquartile range of follow-up was about 6 to 21 years. Changes in cognitive function over time were measured with linear mixed effects models that included random effects for intercepts and slopes. We adjusted models for demographics, vascular risk factors, and clinical factors. And the race by time interaction term was the effect of interest. And systolic blood pressure was measured as the time-dependent cumulative mean, that is a running average of all systolic blood pressures before each measurement of cognition. This table shows the characteristics of participants by race. Blacks were more likely to be women, younger, and to have higher cumulative mean systolic blood pressure and lower cognitive scores at first cognitive assessment. Here are the results of the primary outcome, global cognition. The table shows coefficients for changes in cognition over time. The first row shows the slope for white men at median age. The second row, highlighted in orange, or maize for the University of Michigan, shows the key effect of interest, the difference in slope between Black and white men. So we first see that global cognition declined significantly over time in white men. Compared with white men, Black men had significantly faster declines in global cognition. And the difference in slope between Black and white men corresponds to approximately 4 years of cognitive aging based on the ratio of slope coefficients for race and age. Now let's see what happens to the difference in slope between Black and white adults after we adjust for mean cumulative systolic blood pressure. In the model adding mean cumulative systolic blood pressure, we see that higher cumulative mean systolic blood pressure is associated with faster declines in global cognition. Adjustment for cumulative mean systolic blood pressure partially attenuated the yearly change in global cognition in white men at median age. An adjustment for cumulative mean systolic blood pressure attenuated differences in the decline in global cognition over time between Black and white men. Further adjustment for antihypertensive medication use did not change the race differences in cognitive decline. Several factors were not included because they were not available before first cognitive assessment in all cohorts, but they tend to influence baseline cognition, the intercept, rather than slopes. So we concluded that compared with white adults, Black adults had significantly faster declines in global cognition than white adults. Cumulative mean systolic blood pressure was associated with significantly faster declines in all cognitive domains. And after adjusting for cumulative mean systolic blood pressure, differences in cognitive slopes between Black and white adults attenuated. And this was true for global cognition and memory, but not executive function. Our study results have policy implications. Adults, especially Black adults, warrant blood pressure management to reduce dementia and cardiovascular risks. Effective interventions to reduce disparities and improve blood pressure control between Black and white adults are likely to reduce racial disparities in dementia. And dementia is a potential outcome for health systems and payers to evaluate blood pressure lowering interventions. So the take-home point is that these results are consistent with Black adults' higher blood pressure levels over the life course, contributing to differences in later life cognitive decline between Black and white adults. So how do we leverage these pooled cohort results to inform clinical care and research? Well, we use these epidemiologic results and simulation modeling to address these knowledge gaps. So why do we need a simulation modeling? Well, there's lots of moving parts. So we have blood pressure, cardiovascular death, dementia, plus race, plus non-cardiovascular death. And simulation modeling is suited to handle these many moving parts. So our team has previously developed a simulation modeling, a simulation model, the Michigan cardiovascular model, using nationally representative National Health and Nutrition Examination Study, or NHANES, parameters to estimate a representative population of the United States and move patients probabilistically through disease states using risk models and separately using life tables to predict mortality. Our team has also developed a Michigan dementia model, or a simulation model for dementia, which is a Markov model moving patients through disease states after dementia diagnosis. So for BP-COG, we combine the two models and link them using BP-COG models from the cohorts to estimate who gets cognitive impairment and dementia, called CID in the figure. And this combined model is called MicroSim. MicroSim is an agent-based Monte Carlo simulation using regression-based models to model annual transitions in risk factors and outcomes. Model assumptions and inputs were derived from the best available evidence, applying a predefined evidence hierarchy with meta-analyses of clinical trials and clinical trials having the highest, being considered the best evidence, and deriving observational evidence from pooled cardiovascular cohorts when randomized trial data could not be identified. MicroSim is coded in Python and designed to model scenarios for preventing atherosclerotic cardiovascular disease, stroke, and dementia. The population is derived from NHANES, and importantly, vascular risk factor levels, global cognition, atherosclerotic cardiovascular disease events, non-cardiovascular death, and all-cause dementia transition rates are primarily estimated using predictive models derived from the pooled cohorts and the results from the BP-COG study. So the MicroSim outcomes are total atherosclerotic cardiovascular disease events, myocardial infarction and stroke, global cognition or global cognitive performance, all-cause dementia, and an outcome we define called optimal brain health. And that is without stroke, dementia, or cognitive impairment, defined as a global cognitive performance score of 1.5 standard deviations less than age, sex, and race standardized means. So we've compared blood pressure treatment strategies in the United, if we had optimal implementation of 3 different blood pressure treatment strategies on cardiovascular and cognitive outcomes. So the 3 treatment strategies are a blood pressure treatment strategy based on the SPRINT protocol, which is the SPRINT trial is the systolic blood pressure intervention trial. The second strategy is a blood pressure strategy based on the 8th Joint National Committee, or JNC 8 recommendations. And the third blood pressure treatment strategy is usual care. For the interest of time, I'll present the results of the comparison of a SPRINT trial-based blood pressure treatment strategy to usual care. In the SPRINT trial, individuals with high cardiovascular disease risk were targeted with a blood pressure target of less than 120 millimeters of mercury systolic. And so what we did is for individuals with high atherosclerotic cardiovascular disease risk in the MicroSim population, consistent with participants in the trial, they were targeted with this policy. So they had to have an estimated 10-year atherosclerotic disease risk of greater than 15%, consistent with the trial. And we targeted a systolic blood pressure less than 120. And we added up to 4 blood pressure medications for each individual above their target systolic blood pressure. And we stopped at 4 because there isn't evidence of greater benefit for adding more than 4 medications, and many trials stop at adding 4 medications. So here are our results. So I'm first going to present the results of just in the overall population before looking at differences between Black and white adults. So we found that optimal implementation of a sprint-based blood pressure treatment strategy compared to usual care in the United States, when averaged across all Americans, reduced annual atherosclerotic cardiovascular disease events by about 77,000, and would produce about 0.4 more years of stroke or MI-free survival. So there is a reduction in atherosclerotic cardiovascular disease. A sprint-based BP treatment strategy versus usual care in the United States had somewhat different effects on the cognitive outcomes. So it improved survival and years spent with optimal brain health. The average patient with hypertension lived 0.19 additional years and 0.3 additional years in optimal brain health. A sprint-based strategy for blood pressure increased the numbers of years lived without dementia. However, it increased the total number of individuals with dementia, mainly through more adults surviving to advanced ages. So basically, because there were few people who were dying less of cardiovascular events, they were living longer to develop dementia. So our results suggest that tighter blood pressure control benefits most individuals, but is unlikely to reduce and could increase the size of the large growing population of older adults living with dementia. So now what about the differences in these cardiovascular and cognitive outcomes between Black and white adults? So we found that a sprint-based blood pressure treatment strategy versus usual care in the United States reduced blood pressure differences between Black and white adults. So these are differences in the actual blood pressure levels, but it did not resolve the differences in blood pressure levels between the two groups. A sprint-based blood pressure treatment strategy versus usual care would reduce atherosclerotic events more in Black adults than in white adults, with a relative risk reduction of atherosclerotic events of 13% in Black adults versus 5% in white adults. However, optimal implementation of a sprint-based BP treatment strategy at the population level did not have a substantial relative effect on dementia in either Black or white adults. So what about individual level effects? So here are the results among individuals with hypertension. So a sprint-based BP treatment strategy versus usual care in the United States, individuals with hypertension would gain years lived without myocardial infarction, stroke, and dementia, and years lived with optimal brain health. But there were no major race differences in the years of life gained for these outcomes, except that Black adults gained more than twice as many years of life without stroke compared to white adults. So we conclude from these results that tighter blood pressure control benefits Black individuals by reducing stroke, but is unlikely to fix the dementia disparity. So now we'll talk about stroke cog. So again, this is our second study, which is examining the effect of post-stroke vascular risk factor levels and cognitive decline. So the scientific premise for stroke cog is that post-stroke levels of vascular risk factors, such as blood pressure, glucose, and cholesterol, likely contribute to post-stroke dementia, but this is unproven. The knowledge gap is that it is unknown whether lowering vascular risk factor levels to optimal levels reduces post-stroke dementia risk, independent of the impact on recurrent stroke prevention. So stroke cog has 3 objectives. The first 2 will use the pooled cohorts, and the third objective uses simulation modeling. So the first objective is to quantify the influence of post-stroke vascular risk factor levels on post-stroke cognitive trajectories in dementia using a pooled cohort analysis approach. The second objective is to clarify the relationships between stroke subtype and post-stroke cognitive trajectories in dementia, and whether vascular risk factor levels explain any of those associations. Again, this is using pooled cohorts. The third objective is to quantify parameters of trials that are adequately powered to find effect sizes of vascular risk factor lowering on post-stroke dementia using simulation modeling. So the overall research question is, do higher blood pressure, glucose, and low-density lipoprotein cholesterol, or LDL levels in stroke survivors contribute to cognitive decline? For this study, we did a pooled cohort analysis using individual participant data from 4 longitudinal cohorts in the United States between 1971 and 2021. The 4 cohorts are ERIC, CHS, FOS, Framingham Offspring Study, and REGARDS. So we co-calibrated 109 cognitive test items from 27 cognitive instruments into domains for global cognition, memory, and executive function using item response theory methods. The primary outcome was change in global cognition. The sample included 982 participants free of stroke and dementia. 29% were Black, 49% were women. The mean age at incident stroke was 74, with a range of 44 to 96 years. And median follow-up was 3.9 years, with a 25th to 75th percentile interquartile range of 1.8 to 6.6 years. The modeling approach was similar to that in BP-COG, except the main independent variables were time-dependent cumulative mean post-stroke systolic blood pressure, glucose, and LDL levels. And these two were running averages of the post-stroke levels of these risk factors before each cognitive assessment. Importantly, we controlled for pre-stroke vascular risk factors and pre-stroke means of systolic blood pressure, glucose, LDL cholesterol, and cognition in order to isolate the effect of time-dependent post-stroke vascular risk factor levels on post-stroke cognitive trajectories. So what did we find? So we found that cumulative mean post-stroke systolic blood pressure and LDL levels were not associated with any cognitive outcome. We did find that higher cumulative mean post-stroke glucose level was associated with faster decline in global cognition after accounting for cumulative mean post-stroke systolic blood pressure and LDL levels. So the limitations of this work are that post-stroke cognitive trajectories are limited by the fixed nature of the visits and the variable timing of the strokes themselves. So we conclude that these results suggest that higher post-stroke glucose levels are associated with faster global cognitive decline. We found no evidence that post-stroke LDL and systolic blood pressure levels are associated with cognitive decline. So we're now doing the analysis for AIM-2, which is looking at the association between stroke subtypes and cognitive decline and whether vascular risk factors explain those associations. And we're doing the simulation modeling to examine and leverage the results of the epidemiologic findings about glucose, higher post-stroke glucose levels being associated with faster global cognitive decline to estimate trial parameters of a trial looking at glucose lowering as a way to reduce post-stroke cognitive decline and dementia. So now I'm going to turn to cognitive data harmonization. So this work is led by our team of 2 clinical neuropsychologists, Dr. Emily Brisegno and Bruno Giordani, who are at the University of Michigan, as well as Dr. Alden Gross, who is an epidemiologist and cognitive harmonizer extraordinaire at Johns Hopkins. We've also sought input in this work from our neuropsychologist colleagues on the project, Dr. Jennifer Manley at Columbia and Dr. Ron Lazar at the University of Alabama at Birmingham. And as you've seen, a primary outcome for BP-COG and stroke-COG are trajectories of cognitive function. And so the cognitive data harmonization is critical to developing this outcome. And so the team was tasked with creating a harmonized cognitive outcome measures. So the first step was to identify instruments for inclusion and harmonized scores. So they classified each cognitive instrument item into factor score domains. So the 3 factor score domains are global cognitive performance, which is the primary outcome, memory, and executive function. They also performed some new exploratory domain classifications for potential use for the stroke cog population, including classifying cognitive tests as primarily verbal or visually mediated, items assessing language, and items assessing motor function. And then Dr. Briseno first authored this paper on the extensive pre-statistical harmonization work that she led. So the overall harmonization approach is to first identify the cognitive instruments for harmonization, then to identify the cognitive instruments, items, and variables for each cohort, then to identify equivalent cognitive instrument items and variables, and then prepare them for statistical harmonization. So the team did a deep dive to ensure that the data for a particular cognitive test variable can be interpreted equivalently across the cohorts. They looked at important minutiae, such as the test version, any adaptations made by the cohort, administration and scoring procedures, and coding procedures. They requested information like protocol forms, administration, and scoring instructions from each cohort. They reviewed and documented all of this information in very busy spreadsheets. They then use this information to inform our decisions about the degree to which they are confident that the data for an item can be linked or considered equivalent across cohorts. They also perform any recoding that may be needed and other data augmentation strategies, such as Windsorization, to facilitate the linking of potentially equivalent items. So Dr. Alden Gross is leading the statistical harmonization work. His approach relies on item response theory and confirmatory factor analysis methodology to co-calibrate available cognitive test items. The advantage of this approach is that it allows us to make inferences about cognitive domains instead of individual cognitive test items. And it allows us to resolve the challenge of different cognitive tests administered across the cohorts. We use all available cognitive test items, including tests that are common across cohorts and tests that are unique to individual cohorts. And these items are used to generate factor scores representing global cognition and domain scores of memory and executive functioning. This approach allows us to use all information from cognitive instruments in each cohort and generate factor scores with the same meaning across cohorts. And this approach has been used and described in other research, and it's been used empirically with evidence that the factors have the same meaning across data sets, even with different cognitive tests. And Dr. Gross and his team have shown empirically that this item response theory approach produces cognitive scores that are more precise than those derived from z-scores. So here's the summary of the cognitive instruments considered for inclusion in the harmonization process for stroke cog. This is a bird's eye view at the cognitive instrument level. The cells highlighted in maize represent potentially overlapping cognitive instruments across cohorts. And on the left, you see that all instruments were considered for inclusion in the global cognitive performance factor score. And then they created domains for executive function and learning memory. And they've assigned the cognitive tests to the different domains. Importantly, the team excluded instruments measuring literacy and general knowledge due to their limited sensitivity to cognitive decline. And they also excluded measures of motor functioning for stroke cog given the stroke population. So the team identified 109 cognitive instruments for our primary outcome, global cognitive performance, about 50 of which were linking items across at least 2 or more cohorts. Here you can see a network plot showing the number of global cognitive performance items in common across cohorts. The thicker the line, the more items are in common between two particular cohorts. And we have these split within cohorts as well, so that we can separate, for example, data from the 6-item screener from the regards cohort with data from the more comprehensive global cognitive assessments in the other cohorts. So the team has performed some diff or differential item functioning analysis across cohorts. This is an important step. So the goal was to evaluate the quality of our linking items across cohorts and to check the assumptions made at the pre-statistical level. And for StrokeCog, they found that 24 of 109 unique items showed diff. They then reviewed each of these items carefully to address any coding errors and confirm their decision-making for the linking items. They then examined the impact or salience of that diff. So if we were to adjust for the diff in those 24 items, then we can report the proportion of the sample whose scores would change by a meaningful amount, which is about 0.3 standard deviations. We found that only 6% of the sample had meaningful or salient diff. And we've also considered the fact that we have a bit of a liberal decision-making approach for linking items for this study in particular, given that our primary goal is the measurement of differences in cognitive decline across individuals rather than cross-sectional cognitive scores. So in summary, my talk title asked whether is the whole greater than the sum of the parts. And so I would argue that pooled cohort studies can produce compelling results, that the whole is greater than the sum of the parts. And it might be better than you would expect from the individual parts because of the way they combine adds a different quality. But the process matters. So I haven't shown you, but we spent a tremendous amount of time harmonizing all the covariates, the non-cognitive measures across the cohorts with very busy Excel spreadsheets and deep dives into the administration and protocols for all the cohorts for measuring every variable. And it's important to have attention to detail and fully understand the individual cohort procedures for measuring every variable. It's also important to involve content experts, for example, neuropsychologists for cognitive data, and also to examine cohort heterogeneity. And we do that as a continual process, starting with identifying the variables all the way through analysis, where we typically do pooled cohort analysis and then within cohort analysis. Thank you, and I'm happy to answer any questions.
Wow. My head is spinning right now. What incredible work, especially with regard to harmonizing data. We're attempting to do that in 2 of our projects now, cancer-related projects. So let me ask the first question. What are the biggest challenges with regard to harmonizing cognitive data?
Yeah, so I think it's having a clear understanding of the protocols. So, and actually getting one's hands on the actual protocols, and in particular, the instructions that the interviewers were given. So I know the neuropsychologists, particularly Dr. Briseno, spent a lot of time trying to get the actual, instructions for how the tests were scored, administered, what were considered wrong answers, because there is a little bit of flexibility about that, and cohorts can administer the tests differently. And so, on paper, when we submitted the first grant, it seemed that cohorts, had some of the administered the same cognitive tests, but when we dug down into it, we found out that they, the way they administered it was very different across the cohorts, or the way they scored it and things like that. So
Timing of the assessment, that has to be absolute. That's what we're finding. The timing of the assessment as well. Yeah.
Yeah, say more about that.
Well, you know, with ours, let's say a food frequency questionnaire or some type of physical activity assessment. When was it assessed, right? Not just across the study. When were blood samples collected?
Yeah.
Was it
Yes.
fasting? Was it postprandial? You know, what was the order of the assessments? Oh my God. And you're right. Everybody just says, yes, these will be harmonized. But when you get into harmonizing, wow, it's a big task. So that's
Yes.
incredible. Your work. Um, I'm wondering one more thing. Can you give a lay explanation just of simulation modeling? I know some of our students are, you know, rising up in their statistical prowess, but probably not that far up the ladder. So if you had to explain it to your mother, what would it be? What would your explanation be?
Yeah, so that's a good question, and Melinda might be able to chime in since she does a lot of simulation modeling. So I view it, and maybe incorrectly, as a way of simulating, you know, experiments in populations that it would be very hard to do randomized trials in. And so, and you know, using statistical methods for moving people, you know, from state to state across time, and to estimate the, you know, effects of interventions in these simulated populations. Yeah.
Melinda, do you have anything to add to that?
No, I think it gets really complicated really fast.
Yes.
Many, many, many different ways to do a simulation, and the nitty-gritty matters.
Yeah. Okay, other questions for Dr. Levine? No. Okay, talk about your clinical work and the most satisfying aspects of your clinical work.
Oh, I'm happy to do that. Thank you.
Yeah.
So yeah, so I am often the first provider to see patients with recent stroke after they've left the hospital. And so, you know, the goals are to obviously implement, you know, secondary stroke prevention measures to reduce the risk of having another stroke. And so I focus a lot on lowering blood pressure, controlling diabetes, and lowering cholesterol, and encouraging folks to, you know, quit smoking and increase physical activity as they can with their stroke deficits. But I also provide transitional care as they transition from the hospital or the rehabilitation facility to the community, and address any new medical complications that occurred after the stroke. But I also see two other roles. So one role is educating them about stroke and risk factors, and the fact that we can reduce the risk of people having a second stroke by 80% or more with our treatment strategies of controlling their risk factors and things like that. So to give them hope about that. But I also let them tell their story and listen to their story about the stroke. And I would say many of the patients feel the need to do that. It's been a traumatic event. And the hospitalization, you know, often is, you know, busy, and, you know, certainly there are some cognitive effects that most stroke patients have acutely during the stroke. And so I find that hearing and listening to the stories of patients describing what happened to them, that's a very common thing. it, informs my research, but also allows me to provide some, validation, some hope, some compassion, and encouragement that they're going to get better. I mean, when I see them, it's so acute. Like I used to usually see them within a few weeks of the stroke, that they are going to get better than they are when I see them. And that's really important for them to hear. And they tell me that it's important for them to hear that they're going to get better than they are right when they see me. So yeah, I mean, I just get so much satisfaction from my stroke clinic. It's a unique population, and they're in a really it's a terrible thing to happen to anyone, and yeah, you can provide a lot of positive positivity and hope and compassion to them in a difficult time.
So it seems to me that post in stroke care has become much more aggressive over the past, I don't know, 4 or 5 decades. So what is being done now with regard to either exercise during rehabilitation or prescription for exercise? Because I know it's hard because you're compromised, but you still have to do it.
Yeah, that's a good question. So obviously so for many patients, we encourage the American Heart Association guidelines of 30 to 60 minutes of exercise 5 days a week, as they're able to do, and that they're obviously I make sure that I want them to understand that they need to be safe, right? And now that I'm non-weight bearing on one leg, I understand that they need to be safe when they're doing their exercises. So so that's I would say that we are encouraging them to be more active earlier. I think certainly even when I went into practice 25 plus years ago, we would allow their blood pressure to run high for weeks, and we would kind of want them to rest and not do exercise, and you know what I mean. And we were there were concerns about lowering the blood pressure acutely after stroke would worsen the stroke, and that certainly is the case within the initial days after the stroke, that we do allow permissive hypertension. But by the time I see them at 1-2 weeks out, we can implement blood pressure lowering, and we can have them start doing exercises as they're able, and initiating rehabilitation as soon as possible. So yeah, I think it's gotten more aggressive.
Yeah, thankfully it has. And I appreciate your life course approach to this, because, most of us now, cardiovascular disease has become a pediatric disease. And so imagine that burden longer and longer and longer across the life course. What that means for dementia care, for brain health, for et cetera. So I appreciate that life course approach. Okay, any other questions? I've asked enough.
Yeah, do people have other, do any of the folks on the call in the seminar have any experience pooling data or trying to look at different variables across studies?
It's a relatively new kind of harmonization, as far as I know it. I started learning about it maybe 10 years ago, maybe, with pooling to, and mostly as it relates to measurement of physical activity, right? How much are you doing?
Yeah, and I think one takeaway is that we do the pooling because it allows us to answer questions that we couldn't with one cohort or one study alone, and often, and it provides the the power to look at effect modifications, so differences by race or differences within groups that we need a larger sample size than one cohort provides. And certainly with the case of stroke survivors, there are relatively few stroke cohort studies that have pre-stroke cognitive assessments. Often, the majority of stroke studies historically have been inception cohorts where they're recruited at the time of the stroke when they're in the hospital. And so having pre-stroke cognitive assessments is helpful. But we have the trade-off with the cohorts that they weren't designed to be, to be stroke cohorts other than regards. And so the timing of the stroke relative to the cognitive assessments is variable. They say if you can't get the data you want, you love the data that you're with. So that's what we do.
Okay, well, this has been wonderfully informing. And once again, thank you, Dr. Levine, for this seminar. We see lots of hands applauding. And those of you who are followers, look forward to the next advertisement for talk number 6. Okay, thank you.
Thank you. Have a great week. Bye.